Welcome everybody from IRCAD Strasbourg for the first e-congress organized by IWAS and IWC under the auspice of IFSSH, APFSSH and FESH. We have a prestigious panel of international experts. You'll have 2 lectures, 2 live surgery, and a discussion of clinical case. At any time you can interact or ask questions by live chat. Lorenzo Merlini will be there to collect your question and can intervene when and how. Thank you.
So thank you, Christophe, and welcome to this e-congress. So we will start with Clara Wong, who will talk about the arthroscopic bone grafting for scaphoid non-union. Where are we in 2019?
Thank you very much. Thank you, Professor Martheline, for letting me to be in this e-congress. So I'd like to talk about the arthroscopic bone graft for scaphoid non-union. And the first arthroscopic bone graft was done in 22 years ago by Dr. P.C. Ho on a 50-year-old man with a history of scaphoid fracture fixed with a percutaneous screw, but resulted in non-union. And then he did the arthroscopy and get the bone graft from the ID crest and impacted to the non-union site and found the patient fracture healed well and with good function. So far until 2019 in January, we performed 139 cases. So in the period of time till December in 2016, we performed 125 cases. Most of them are men, the average age of 28, and 111 cases were non-union, and 33% of them were smoker, and most of them have the problem occurring at the middle part of the scaphoid, and 42 happened in the proximal 1/3, and 60 of them have DC deformity, and about 20% of them have radiological snag wrist changes. So now I'd like to talk about the surgical technique. This is a 38-year-old man with scaphoid non-union for 2 years' time. So in this wrist X-ray with outward deviation, you can see the gap at the non-union site. So the operation can be performed initially under local anesthesia so that the patient is awake, can be able to watch the TV and know about his condition, and then he will then be cooperative with the post-operative rehabilitation. But you can also convert to general anesthesia in the later part of the surgery. So the first part is under local anesthesia. With the portal site local anesthesia, we develop the radiocarpal joint through the 3-4 and 4-5 portal, and we enter to the radiocarpal joint mainly to see the condition of the cartilage condition and also the any involvement of the fracture site entering to the radiocarpal joint. And then we go to the mid-carpal joint. We start with the mid-carpal ulnar portal first so that we can delineate exact the site of the mid-carpal radial so that it will be the later bone graft site so that the tackle point could be exact. Sometimes if there's a distal scaphoid non-union, then we may need the STT joint portal for the direct access to the non-union site so that it can make this bone grafting easier. So after getting into the joint, we remove all the avascular zone, including the sclerotic bone, necrotic bone, and also the bone cysts and all the interbolus fibrous tissue until that we can find the bleeding bone at both the proximal and also distal side of the fracture fragment. And then we put down the wrist from the wrist traction tower and extend the wrist so that, bend the wrist so that we can reduce the radiolunate joint and putting a pin across the radius and to the lunate to correct the DC deformity. And then we extend the wrist so that the humpback deformity over the scaphoid union can be corrected. This is a schematic diagram showing you how we reduce the humpback deformity by first bending the wrist to restore the radiolunate angle and then extend the wrist so that the scaphoid humpback deformity can be corrected and resulting in a space there where we should put in the bone grafting. And then we put a pin across the 2 fracture fragments. We aim the position of the pin be more volar and also more radial so that it won't hinder the impaction side of the bone graft. And it's good to see the alignment of the pin from the semi-supination view that we call it a spin view. And put up the wrist in the traction tower and see the across the pin across the 2 fragments, and then make sure that the first batch of the bone graft can be being pushed underneath the pin so that later the impaction bone graft won't be hindered by the pin. we have to harvest the bone graft from the early crest, the cancellous bone graft. The amount of bone graft should be about 3 to 5 times more than the original defect. That means we have to impact the bone graft. The bone graft density should be about 3 to 5 times higher than the original bone density at the early crest. And after the bone graft being impacted, we insert the tissue glue, which helps to conceal the bone graft from the joint fluid extra dilution to the osteogenic component of the bone graft, and also prevent the mechanical irritation of the bone graft because of the rough surface onto the cavity cartilage. And then we put down the wrist, add on 2 to 3 more K wires across the fracture site, and bury the K wire underneath the skin, and keep this K wire for about 10 weeks' time. So in our cases, 38 cases need screw and 87 cases need K wire, but indeed the screw fixation is only needed if the proximal fragment is big enough with good bone quality. So this is stitchless operation. This immediately after the operation, and this 2 weeks after the operation, the scar is inconspicuous, and it is the case of with a screw fixation. You can see the bone healed nicely in 3 months' time. So how about if a fracture line goes into radiocarpal joint, then we can insert a Foley catheter through the 3-4 portal, inflate it, so to prevent the spillage of the bone graft through the impactions from the midcarpal joint. So if the screw is in situ, but the avascular zone is big, then we have to remove the screw so that it won't hinder you to remove the necrotic bone and also fibrotic tissue in between, and then do the normal arthroscopic bone graft as usual, as shown in this video. Then you can see the fracture finally healed nicely. So how about the proximal port non-union? For proximal port non-union, then usually the operation is faster because the bone need to remove is smaller in amount and also easier. And as shown in this video, then they remove all the necrotic tissue, correct the bone cysts, and they put the bone graft harvest from the early crest. That it's good that Professor Martin advocate to put a pin through to the lunate region to guarantee the security of the fixation between the proximal and also distal pole. So if there is a malunion, arthroscopic bone grafting also is helpful. We can use the osteotome to break down the malunion site, and as the usual arthroscopic bone graft for non-union, we have to reduce it as the method that I mentioned before, and then insert the K wire. So if there's neck risk changes, it's also not a contraindication. As shown in this case, a 34-year-old non-union for 16 years and painful for 2 years' time. And we did the arthroscopic bone graft in addition to the radial styloidectomy. So this is his condition 19 years after the operation. He's quite painless, and also the wrist range of motion is nice. You can see this is the X-ray appearance after the operation. So in 125 cases, one lost follow-up, we found that with the proximal fragment with good vascularity, the urine rate is 95.4%. With poor vascularity over the proximal part, the urine rate is 81.8%. But for those, how about though after the arthroscopic bone graft still not healing? In those cases, we have 7 revision operations, and 4 of them we redo the arthroscopic bone grafting. And inside the operation theater, we found that indeed the proximal and also the distal fragment with good vascularity. And then we repeat the arthroscopic bone grafting and found that the fracture healed nicely, as shown in this CT scan at 23 months, although there's a prominent bone graft at the dorsal side of the scaphoid. So now we all know that the scaphoid is a bone that's difficult to heal because most of the surface of the scaphoid is covered with cartilage. There's a limited amount of periosteum. Then we don't have enough the osteogenic or chondrogenic cells from the periosteum to promote the calyx to form. So the anatomy make the scaphoid to heal relying on the primary bone healing. That means it needs the rigid stability and direct bone contact. However, the scaphoid fracture itself is inherently unstable because of the scaphoid itself is breaching the proximal and also distal part of the bone. So they have a lot of bending force across the fracture site. And also because of the anatomy of the radial scaphoid ligament and also the force from the thumb is through the SC joint ligament. So resulting in the shearing, bending, and pronation forces on the scaphoid. And also we all know that the vascularity over the scaphoid is a problem. So with the continuous motion of the fracture, it can cause the vascular perforator to recede from the fracture site, resulting in a bigger avascular zone, and more bone is resorbed, bone cysts form, and resulting in bigger gapping. However, arthroscopic bone graft is really helpful. It helps to preserve the vascularity and remove adequately under the magnified view in arthroscopy to remove all the avascular zone. And so we know that healing does not depend on the proximal fragment of blood flow, but depends on the surrounding vascularity and also infiltration from the distal part. And therefore, avascular necrosis is not a contraindication that we can see that in our cases, around 82% of union rate. And also the previous failed arthroscopic bone grafting is not a contraindication for another arthroscopic bone graft surgery, because in our next operation, we found that the vascular zone is actually improved from the previous arthroscopic bone graft surgery. And also this surgery improves the stability across the two bony fragments, because we can correct the humpback deformity, and DC deformity also is not contraindication. And the impaction bone graft make it very tight and very much impacted, so to correct the scaphoid length and provide immediate stability. That it also, this surgery provide the least disturbance to the ligaments. So when the length of the scaphoid being restored, the surrounding ligament restored its normal sturdiness to provide the immediate stability over the non-union side. So therefore, screw compression fold is not needed. So most of the time we insert the K wire. And also the this operation it did not depend on the primary bone healing, and the impaction bone grafts not relies on the bone primary bone healing. It also provides a lot of osteoconduction roles, supplying osteoprogenitor cells, osteoblasts, osteocytes, and also chemotatic mitogen to promote the bone growth. So therefore, in short, in 2019, I think that arthroscopic bone graft is still the first choice for all cases of scaphoid non-union. Thank you very much.
Thank you, Clara, for this beautiful talk. Clara, I have a question. Did you try to do the bone grafting without glue? Did you do any study about the interest of glue with or without?
Bone grafting without the magnification, the loop?
No, with the glue.
Oh, with glue? No, I do the bone graft all with glue, tissue glue.
Okay, so you never tried without the glue?
No, never.
Okay. Is there any other question in the audience? Gustavo?
Thank you for the beautiful lecture. What's your opinion about the use of the distal radius graft instead of the iliac crest? Because we already have experience about the possible osteogenic effect of making the damage on the distal radius. So this is a healing factor, for a plus healing factor, and of course not have to deal with other part of the body.
So for our cases, I have tried about 2 to 3 cases with the bone graft harvest from the distal radius, but all those cases with defect very small. So maybe in all our cases, defect quite large amounts that we need impaction of bone graft, that the volume is not sufficient. Moreover, I think that the osteogenetic component of the bone graft harvested from the iliac crest is much better than distal radius. Then we hope a show-in operation, so that we hope that giving the more bone cells to the recipient side should be better.
Yeah, Guillaume Herzberg, you have a question?
Clara, congratulations. What now are your indications for vascularized bone graft?
For all cases, I did the arthroscopic bone graft. So when it failed, then I will convert to the vascular bone graft. If from the initial operation, I found the vascularity over the proximal part is really bad, and if failed for arthroscopic bone graft, if the subsequent X-ray, I found that the site of the non-union is exactly the site same as the previous operation, then I'll do the vascularized bone graft. Thank you.
Philippe Liverno?
In which case do you prefer using a screw instead of K-wires?
I prefer using K-wire more, because for screw, I worry that the compression force will squeeze the bone graft out and also distort the shape of the bone graft. So I'll use screw when the proximal fragment is really big with good bone quality, and also the gap is not that big that I don't need too much of the cancerous bone graft.
Okay, thank you very much. Now I will call Bo Liu, who will talk about, is bone graft always necessary for scaphoid delayed and non-union?
Thank you. Thanks for the Professor Christophe Marcelin to allow me to include me in this wonderful international high-level educational platform.
And apparently after the talk of the Professor Clara Wang, there's no need to talking about the bone grafting, so my talk is bone graft always necessary for scaphoid delayed union or non-unions? And we always thought that the only reliable method of achieving union by some form of bone graft for scaphoid non-union. So we have seen the popularity of the milestone grafting techniques for scaphoid non-unions actually from as early as 1930s. And after that, you can see from each decade there's one new form of bone grafting technique was described. So we have so many different choice, vascularized, non-vascularized, and arthroscopic approach. So it seems we have enough stuff in our armory for scaphoid non-unions as surgeons. However, are we satisfied with this? So if this patient comes to your clinic, it's my patient, it's with late presentation, present at 8 months after initial injury, and some kind of a bone grafting procedure was proposed for this patient. So what will you do for this patient? We have choice of material C, wedge bone grafting, petticoat, vascularized or arthroscopic bone grafting for this patient. So while the patient was waiting in the surgical waiting list, so 1 month later he come back and take an X-ray and show that there's some change in the X-ray, AP and lateral, and also the CT scan. So we decide to wait, and another month later, gradually this fracture gradually united. So it's just 10 months after initial surgery. So it is difficult to predict this. So more patients coming, the patient present or diagnosed somehow late. This patient presented 2 months after initial injuries, and 2 months after initial again, and even worse is proximal pole and displaced. So the question is, the scaphoid fracture delayed with delayed union, delayed presentation, or early non-union is always bone grafting necessary. So more recent evidence has shown that percutaneous fixation alone can be successful for treating stable scaphoid non-unions connected with fibrous tissue or intact cartilaginous gap. And also, extensive bone resorption at the fracture site is not an absolute indication for bone grafting. So the key question here is scaphoid fracture, delayed union, or early non-union is how is the stability of the fracture? So these are two very similar patients, young patient, 4 months after initial injury, similar X-ray, similar CT scan. That's a non-union or delayed union. That's a very obvious bone loss here. But the fact is, the assessment of fracture stability is difficult. The CT scan and X-ray cannot tell you the stability of the fracture. But with arthroscopy, you can see the first location has very stable fibrous union. In the metacarpal, you use a probe to forcefully push the fracture site. You cannot see any movement at the fracture site. But another similar patient is, you can see there's a gross movement between the fracture site is a obvious unstable fracture. So these two very similar X-ray and the CT scan, but has different finding at the wrist arthroscopy examination. So this wrist arthroscopy allows us to have a direct assessment of the fracture stability without causing significant surgical trauma to the ligamentous and the vascularity of the wrist. So we just have a study which just now published with 25 patients, subacute presentation of ununited scaphoid fractures. And this is one case we have shown this patient has very stable fibrous union. The healing process was arrested due to micro movement and the lack of mechanical stability. So diminishing the micro movement by simple percutaneous fixation without bone grafting is good enough to achieve a healing. This is another scenario with an unstable mobile fragment here. You can see the macro motion at the fracture site and may not be adequately addressed by simple percutaneous fixation. So the replacement of the necrotic tissue and the gap by arthroscopic bone grafting plus percutaneous fixation is also can achieve a reliable healing of this fracture. So more patients coming. We have seen this patient is radiologically is no displacement, but has some bone radiolucent line as a fracture sign, but it is stable. So simple percutaneous fixation again, and 10 weeks later is healing of the fracture. And this is a case with unstable mobile fracture sign as a proximal pole. So in this case, after debridement, we use ABG, and immediately after operation with a KY fixation, and 12 weeks later has a healing of the fracture. So in this study, we achieve 100% union rate, regardless of the stable unstable group. The mean time to union appears shorter in the stable group, but there's no statistically significant. So in summary, the stable, delayed, or early union, so the micro movement can be stopped by the percutaneous fixation, and in this study, arthroscopy approach can allow us to confidently exclude the requirement for bone grafting in over 40% of the patient. And in unstable group, the wrist arthroscopy in our study avoids the mobility of an open procedure. After you assessment the fracture side, you can proceed to the ABG procedure to achieve healing of the patient. So in conclusion, bone graft is not always necessary for scaphoid delayed or non-union. The percutaneous fixation alone without bone graft may be sufficient for stable scaphoid delayed or early non-union, and the stability of the delayed union or non-union could be confirmed by arthroscopically by phosphor probing, which is not cannot be tell you by X-ray or CT scans. Thank you very much for your attention.
Thank you, Boyu. In France, we used to make a difference between before 6 months after the injury or after 6 months. Did you see in your patient if there is any difference if the surgery is performed? Because you have some cases from 2 months after the injury and some other 12 months. Did you see any difference on the union if they had the surgery before the 6 months or after the 6 months? Did you see any difference? Does it change your indication?
Yes, thank you, Gus. So this is a very important question because in this study, we only include the delayed presentation and early non-union less than 1 year. So I think it's very chronic non-union is another scenario. Most of them will require formal any kind of bone grafting and fixation. But for this age group with delayed union, and early non-union, this group we still have a chance to use arthroscopy to assess the stability. So it is a different group. In this group, it's possible to use in stable group, stable fracture. We still have a chance to do a simple percutaneous fixation to achieve the union of the fracture.
Okay, thank you. Philippe Liverneau.
Thank you both for your nice presentation. In the beginning of your presentation, you showed 2 cases, one in a patient with 17 years old and the other one with 13 years old. Still, the growth plate has not healed. Some people have published some papers, and they say that when the growth plate has not been healed, you should not operate a non-union of the scaphoid. So what is your opinion about that? Is there a role of the growth plates in making a decision like operating or not operating a scaphoid non-union?
You mean you use plating as a technique for fixation of the fracture?
No. I mean that the 13 years old patient, she has the growth plate not healed, so she can grow a little bit. Yes. And some people said that when you have this, when it's not an adult, there is a potential for scaphoid healing of a non-union. So don't you think that you have to take this into account when the patient is very young? Maybe you should not operate them because there is a high chance to heal spontaneously.
Yes, Yes, I thank you, Philippe, for this wonderful question, because we all know that the healing potential in the young age group is much higher than the adult, and we also find the patient with delayed presentation, and gradually the fracture can heal by themselves. But we still can see the patient with, even in the young age, if we let it alone, let it go, the fracture will, the delayed union will be proceed to the chronic non-union. So, and we also can see many patients with young age with scaphoid non-union, which goes through the sequelae of the non-union, go to the deformity, go to the arthritis, early arthrosis. So in my opinion, we still need to do some intervention. We use a invasive approach to check the stability. If it's stable, we can proceed to plaster fixation, result percutaneous fixation. Thank you.
Okay, so we follow for the next session. So it's my pleasure to co-chair this session. Thank you for the invitation. And we're going to start talking about the mini-invasive procedures for plating distal radius, a very passionate topic. I had the privilege to learn from Philippe, one of the big centers in the world working in this amazing technique. Please, Philippe Liverneau from Strasbourg.
Thank you, Gustavo. Yes, we all use arthroscopy as a minimally invasive technique for, treating different kinds of lesions like scapholonate, ligament tear. You can load the video. And also scaphoid. But when sometimes you have a distal radius fracture, why don't you use a small incision? So it is possible, and we are doing this in my department for a long time. So I will show you on a dead body first, the technique, and then on a clinical case. So you have to use the FCR approach, but a small one, a little bit proximal to regarding the styloid process of the radius, lateral to the flexor carpi radialis. Then you just put a rongeur below the pronator, and it's possible to respect the pronator. Then you just have to plug a guide on the plate, and this guide is very helpful for this technique, because you can take in your hand the plate with the guide. Then you introduce the plate just below the pronator, like this. Even in this dead body with weak tissues, it's possible, as you can see. Then, like using a tire on a car, you just use an instrument to put the plate below the skin, and then you use a K-wire, the most ulnar and the most distal hole of the plate, which is considered as the pivot point of the plate. And when the position is correct of this K-wire, of course you can navigate it a little bit proximal, distal, radial, or ulnar, depending if the position of the plate was good. And then just put the second K-wire, and you don't take care of the shaft, only the epiphysis. And then when the position is okay, you can put the two central screws through the guide, which is very helpful because it's a fixed angle here. And then when it's done, it's very easy to complete the procedure. So this is very easy for an extra-articular fracture, but it's also possible to use this technique for AOC1 or C2 fractures, if you use some K-wires to reduce some articular fragments. Then when the epiphysis is done, you just remove the guide, and you can see that with this small incision, if you navigate the incision with your retractor, you can see all the epiphysis, and then you can put the most ulnar screw, like here. And sometimes you need a lax screw, like here, if you have a fragment which is displaced and you want to attract the fragment to the plate. So with a lax screw, you can do this maneuver. When you are happy with the distal fragment of the radius, just have to make the reduction with the plate. So what you have to do, still respect the pronator. You put kind of guides like this in the proximal holes of the plate, two ones. Then you just have to push on the proximal part on the plate, and if it is of course a dorsally displaced fracture, you got automatically the reduction. Then you put a drill on the most proximal hole, and this automatically will prevent for the plate moving, and so you can't lose the hole. Then you make another drill, and the first screw, and then the second screw, as you can see here. And then after the fixation has been completed, of course, you have to check that the flexor tendons are not below the plate. Here you can see with this small incision, you respected the pronator, even on this weak tissues, and you can see all the parts of the plate. And if you want even to make your incision smaller than before, you can use this intradermal suture, and then you just have to pull on it, and you will get even a smaller incision. The record we have in my department is 5 millimeters. We started with 15, and then we cheat on it, and it's even smaller than for a carpal tunnel. And here, 1 centimeter. So now we see a clinical case. So you remember that this is one of our very first cases we did some years ago. So the incision should be a little bit more proximal, because if you are too distal, you will not be able to reach the proximal holes of the plate. It's important to separate the soft tissue very distally and very proximally from the skin. And you also have to cut the fascia between the FCR and the artery, and to get the same space as if you were in a large incision. You know, I used to say to Obey, you know, I make a small incision. If I get a problem, I can make it larger. And you, with your large incision, you can't make it smaller if it is large. So why don't you start with a small incision, and in a case of problem, you can enlarge it. So here we put the as on the dead body the plate below the pronator, and again the pivot point of the plate is the most ulnar and the most distal hole. You put a K-wire here, and then you check on the X-ray if the position is correct. Then you use the second one, the most radial and distal one, and you rotate. Usually the plate is a little bit oblique due to the anatomy, and with this forceps, you just rotate the plate, and when you are happy, you put the two central screws, like here. It's another guide, but it's exactly the same principle. Remove the guides and put the screws, central screws inside. And when the two central screws are okay, you have to remove the two medial and lateral K-wires, and it's important to put all the distal screws from the epiphysis before doing the reduction on the shaft, because if you do this before, probably the fixation of the plate on the bone could be too weak, and when you are doing the reduction, you may have a secondary displacement. So it's important to put all the screws inside. Here we check that the flexor tendons are okay, and then again we just flex the wrist a lot in order to use the elasticity of the skin to get some space, and put the two guides, one drill. Don't remove the drill, because if you remove the drill, the plate will move a little bit, and you will not be able sometimes to find the hole again. Of course, this is very important. Then you remove the guide, you put the first screw, proximal screw, and then the second screw, and then it's easy. Sometimes when the fracture is complex, you can use external maneuvers or some K-wires to help for the reduction, even arthroscopy if there is an intra-articular fragment, or if you want to check that there is no ligament here. But in this more than 80-year-old lady, it's not necessary to check the ligaments, of course. Here it was our first cases, and we just use stitches like this. But it's better to use intradermal, because you can make as I told you before, even more smaller incision. We don't use a splint we ask to our patients to move in immediately. And this is an example of a patient after 2 weeks, and she looks happy. You can see an hematoma here. It's because she got also a dislocation of the elbow, and after 2 weeks, the patient even can move everything. And here you can see that we have only 1 centimeter incision at the end. Thank you for your attention.
Thank you, Philippe. It's always a pleasure to hear you talking about this technique. We've been talking about this for a long time, maybe 10 years. I would like to ask you, you've shown these beautiful cases, some special implants with special instruments. Do you think it's possible to use the same technique with regular plates available in the market?
Yes,
How is your tricks for regular implants?
Well, I think it's possible with regular implants, but it's difficult, much more difficult, because if you have dedicated instruments to do it, it's better. For instance, when you don't have a guide with your plate below the pronator, if the plate is a little bit rotate, it's difficult, to put the plate at the right position. If you have a guide outside of the skin, just take it in your hands or with the forceps, you can modify the position of the carrier easily. So yes, it's possible, but it's easier with a dedicated guide.
Okay. And your impression as a benefit, despite only of the cosmesis, you have the same impression as me that the post-op rehabilitation and the post-op pain is much lesser than the traditional approach?
Yes, because the people even don't realize that they have been operated for. Actually, the incision is like this, below the skin, like common conventional incision. But it is very small, sometimes 15 millimeters. So the patient even don't realize that they have been operated for a distal radius fracture, and they just move. If you use a cast or a splint, after 6 weeks, the patients are like this, and they say, "Thank you, doctor." And after 2 weeks with this kind of operation, they say, there is 10 degrees less. So, they are more confident, and they are more demanding, actually.
Thank you. Any question from the audience to Professor Livernon?
One question. I want to see when you take it out. Is the same or finally you cut the pronator quadratus and...
Very good question. Now, we published a paper a couple of years ago with more than 500 removal. And of course, we use the same technique, and we have, at the end, smaller incisions than the first time. Because, as I told you, you can cheat with when you pull to the intradermal suture. So yes, we respect the pronator, and we take a picture of the pronator of each patient after we remove the plate, and we can demonstrate that yes, finally we got a very, very small incision.
When you make the reduction of the fracture, do you have a plate malalignment on the shaft?
Yes. Yes, of course, there are mainly two kinds of fracture, volarly displaced and dorsally displaced. When it's volarly displaced, I didn't show here, we use the conventional technique, as meaning the oblong hole. When we navigate the oblong hole, we use it first. But for dorsally displaced fracture, as I said, the most important thing is to reduce the epiphysis, the distal part of the epiphysis. And because the plates we use nowadays are anatomical, if you respect the watershed line and so on, the distal part of the plate will be at the correct position. You don't take care of the reduction on the shaft. And when the epiphysis is strong on the plate, you just have to push on the plate, and sometimes to rotate a little bit to get a good reaction. And Guillemersberg insists on something very important, the lateral translation of the displacement. Sometimes you get it, and sometimes it's very difficult to get a reduction. So in this case, we just put the plate in the epiphysis, and then we use the intrafocal K-wire to get the reduction of the radial translation, for instance. Then we put the screws, and then we remove the key wire.
Guillaume?
And what about a very, very distal line?
Very good question. So in this situation, we use two distal rows plates. Then we use the very distal row. And of course, in this situation, we are above the watershed line. And we tell the patients, don't move too much to make so a lot of weight bearing and so on. And then after 3-4 months, we remove very early the plate to make sure that he will not get a problem of tendons. And also on the market, there are specific plates for that.
Okay. Thank you, Philippe, very much.
Thank you.
So it's my pleasure to call our friend and master, Professor Christophe Matulin, to talk about arthroscopic bone grafting in bone lunate ganglion.
Thank you. You can start the video. You know that this kind of ganglion is not rare and became painful when there is a fracture of the cortical bone into the joint between the scaphoid and the lunate. The technique is very simple, but classically the ganglion is volarly to the lunate, and the open technique is very complicated because you have to perform an open surgery and a large approach to open the joint and find the ganglion. Arthroscopically is very simple. You perform a classical 3-4 approach, portal, as usual in a radiocarpal portal. We start with the placement of the trocar and into the joint. At this period, I use a dry technique. It's not a problem for me, dry or wet. And you find the 1-2 portal. You enter in the 1-2 portal, and it will be the portal where we have to place the scope. And this way is very simple, and you have a direct aspect of the scapholunate ligament. In fact, it's not a problem to pass through the scapholunate ligament, the proximal part, because we know now that this part is unvascularized, so it's not a problem at all. You don't create any damage. So with the needle, you pass through the proximal part of the scapholunate ligament. You enter, and with your shiver, you start the cleaning of your ganglion. It's not really complicated, and step by step, you use a curette. You see here inside the lunate, and you can imagine that it's absolutely impossible to have this kind of quality of vision by open surgery. And step by step, you curette all the ganglion in order to find the correct safe bone at the end. And it's not very long operation. For that, you need 1 or 2 minutes with the shaver and the curette in order to clean everything. At the moment where you have to put the graft, of course, if you use a wet technique, you have to pass to the dry technique in order not to have a moving of the graft into the joint. So here you see very well the ganglion. So for the bone grafting, I use a JAMGD system, and I perform a very small approach either on the lateral aspect of the radius or on the dorsal aspect of the distal Lister tubercle. So I use this system. You see, you have a heavy drilling into the bone, then you harvest the graft like that without problem. And after that, your scope is in, you see that we are in a dry technique now. Your scope is a 1-2 portal, and you enter with your JAMGD, and the graft is inside the trocar. So it's very easy. You enter and you go directly into the bone graft. And once more time, you imagine the complexity of the open technique comparatively to the simplicity of the arthroscopic technique. So you push the graft inside, is not complicated at all, and normally you need for the big ganglion 2 or 3 different passage with the jump GD with the graft, and you push here. So you see in this case it's not sufficient, so you have to perform another graft. You push the graft with the system, not complicated. Here, and you push the graft inside the ganglion until you fill it completely. So in this time, you know, in this case, you know that it's not totally sufficient. So you come back to harvest another part of graft in other direction, obliquity, of course, in order to take into account the obliquity of the radius, not to enter into the joint. It's the same for the pseudarthrosis of the non-union of scaphoid. When you perform the graft, it's the same principle. And here you see the second graft, and you push like that. You see, it's almost the normal time. You see, it's a very short operation. In fact, it's very simple for the patient. There is no stitches. So here it will be okay. You fill completely the ganglion. You finish the operation like that. Okay, okay. And you know, the ganglion is totally filled. You push, you can let open, of course, the proximal part of the scapholinate, which is not damageable for the patient. I promise you, it's not a useful part of ganglion. So after that, it's okay. You can remove, it's not necessary to place any stitches. You remove the traction, and you perform a cast for the first week until the first dressing. Now, classically, I visit my patient after 5 days, and I put a simple splint, and the patient can remove the splint to have a normal shower. And you see the patient at the first dressing, and you see the scar is not is cosmetically totally acceptable. Thank you very much.
Thank you, Christophe. This is a very interesting example of how the arthroscopy can open new gates and new possibilities for us.
Yeah.
And especially I've become very astonished by this scapholinate approach. So it's
Yes, in fact, you know, you don't have to forget that the wrist arthroscopy, the arthroscopy is a tool. It's just a tool, but it opens a large field of indication, and we understood really better the anatomy and the different parts. 20 years ago, it was just unimaginable to pass through the scapholinate, the proximal part of the scapholinate ligament. Now we know that it's a unuseful part of the ligament, and in degenerative case with elderly people, you see that there is a normal joint without the proximal part, so it's very easy to pass through the ligament.
Thank you. Any question?
Yes, sometimes the ganglia assist is very volar. So do you propose to use a volar approach in this case, or is it enough with your approach?
No, absolutely not. A volar approach is too complicated. You can use a volar approach if it is dorsal, because I have a case like that. It was a triquetral, on the triquetral side, ulnar side, and I pass volarly, and the ganglion was dorsal, but it's very rare. No, for the volar ganglion, because the ganglion is classically volar, you have to pass dorsally. If not, you cannot attend with the obliquity is a better place.
3 short questions. First one, why the nurse is maintaining the wrist in extension while you are doing the splint? How long? The second one, why don't you use a splint directly the first day in OR?
Yes.
And the third one, how long do you splint them?
Yeah, you're right. Is an habit. So it's very important. The first part of the question is not extension, in fact. I put like that an extension, but at the end it's a rest position. You have to understand that the wrist, when you are in this position, it means the straight position, is not comfortable at all. You have to contract your flexor carpi ulnaris and carpi radialis to maintain the straight position. The rest position is like that. So the comfortable position is in slight extension. So I put the splint in this position. With this position, it's very comfortable for the patient. He can drive the car, he can use the computer, he can phone, he can write, he can do everything. And you're right, why I don't splint immediately? It is my habit. I like to see the patient after a few days. I put a large dressing in order not to have any pain during a shock or injury. And after that, I remove. It's my habit, but you're right. Maybe you can splint immediately. How long the splint? 6 weeks, but I don't know why. Thank you.
I invite now Professor Olivier Naud to replace me and chair the next session of discussion of clinical case. Thank you very much.
So now we will have a session of clinical cases, and I will ask some people from the second row to give their advice. So please be happy. There is no good solution for all of these cases. Actually, none of these cases have a solution. So be quiet. And we only would like to get your advice and your way of thinking on these cases. So the first case is from Jeff Ecker. It's a 17-year-old elite tennis player. He got a wrist pain when hitting forehands. And this is the MRI. Okay? So you can see that there is something on the lunate. Okay, I can, if you want, I can go back. So there is an edema in the distal portion of the lunate, as you see, and the pain responds to rest, and the edema in the distal lunate disappeared. Okay, and now this is the MRI couple of months later, and you can see that there is a kind of ganglia cyst on the tricuspid lunate part of the wrist, dorsal one. So problem is that when this patient returns to the tennis activity, he presents the same recurrent pain, and there is this intracapsular dorsal tricuspid ganglia. So first question to Adrian. I noticed that you took some notes. So what is your diagnosis for this condition?
Well, I think it's important firstly to decide, is it really mechanical or is it maybe non-mechanical? So it's possible that there's a neurological component. So I'd like more detail from the history. You are suggesting a mechanical situation.
Yes. So what you have to know is that Jeff is not here. I don't want to answer you. You don't have to ask me questions. you have only this. What is your first diagnosis? Even if it's crazy, this is what we are waiting for you. 17 years old, elite tennis player, wrist plain when doing tennis, edema of the lunate, a ganglia cyst. When he stopped playing tennis with a splint, is okay. Even the edema disappear. So this is the only information I have.
Sure. So I would think of a neurological component. I would assess his posterior intraosseous nerve. I would maybe give him a trial injection and see what that does. If there is no response to that, I have to accept that there's an intra-articular component, and then probably I would scope him to find out if there's instability in the lunotriquetral area.
Okay, that makes sense. Jean?
It seems to me that kind of overuse of the wrist, so I would treat as suggested with the resting and maybe with the pulsed ultrasound that make reinforce the bone. And then if the pain persists, I would do another MRI to see if the edema has resolved. If the pain persists, but the MRI is negative, I would consider this ganglion, because I've treated several sports persons, a very young one, like around 17 to 20, that had pain, and they had occult, very big occult ganglia. You couldn't see anything from outside, and then when they asked for the surgery, I removed a very big ganglion, which was under between the capsule and the tendon, and was bothering them, and they solved completely the symptomatology. So if the MRI remains negative and the lunate problem is solved, I would consider that the ganglion may bother the patient. Maybe I would do a scope just to check in the joint if there is any problem in the joint. But the problem would be if the MRI does not heal.
We will see later.
Okay.
Anyway, we don't have a solution. So the proposition of Jeff is that it's a non-dissociative mid-carpal joint instability. It's only a proposal like yours. So then, treatment, so you already discussed about that. So Guillaume, do you have an idea of what would you, not the diagnosis, but what would you do now?
Yes, but I am very sorry because I'm unable to advise any treatment without a diagnosis. And I think in this case, we are missing two very important things. First of all, as you know, I'm a fan of clinical examination, as PCO and many in this audience. And we don't have any information from clinical examination. Number two, in my unit, it's forbidden to show us an MRI without X-rays first. And we even go to the fact that we need bilateral X-rays, and we need 3 X-rays on each side, one PA, one true lateral, and the other one in ulnar inclination. I think in this situation we don't have any information about the geometry of this wrist, so I just passed the question.
Yeah.
Sorry.
Okay, no, probably I don't have the information, but probably the X-ray is quite normal, and the physical examination locates a pain exactly in front of the dorsal part of the wrist, exactly at the topic of the lunate.
A wrist deserves much more than that.
Yeah, I know, but I can't tell you more. I'm only
sorry.
have this. So, okay. As Jean and Adrian suggest, of course, they didn't propose any, Jeff didn't propose any operation first. He tried a conservative treatment like proprioceptive wrist exercises program and continued playing and so on. And he proposed that if the pain doesn't resolve, to make an, as Jean said, an arthroscopic excision of the ganglia, and looking for instability or a tear in the TFCC. What do you think about that, René?
The first step is evaluation for the instability of the all joints in the mid-carpal and right carpal joint. Okay,
yep.
Is the first step, and the second step, excision of the ganglia of the lunotricutal dorsal ligament is important, and the most important is instability on the volar part of the mid-carpal joint. For me, is the view in the MRI is effect in the mid-carpal instability. In my patients, we have 3 or 4 patients we have instability with the first effect is the edema in the distal part of the lunate on the volar part. And I think that the best treatment or the best arthroscopy is the evaluation of the instability and treatment in this moment.
Okay, so imagine that Jeff performed an arthroscopic removal of the ganglia. It doesn't solve pain, and there is no obvious instability, and it doesn't respond to this conservative treatment. So the question of Jeff is, would you consider shortening the ulna? Gustavo?
It always happens to me in the school. The worst question always comes to me. Well, the first thing that calls my attention was this edema in the lunate, showing probably an overuse, just like Jane mentioned. It can be a chronic overuse, or can be some overload, punctual overload, and probably you have an associated overload in the ligament system around the lunate. This mid-carpal instability is also could be associated with some laxity and some loosening of the dorso-intercarpal ligament. It's also some findings I have found in mid-carpal instability, and it's more related to the location of this ganglion. So in the arthroscopic evaluation, I would pay a lot of attention in the dorsal insertions around the lunotricutal ligament and around in the dorsal part of the triquetral bone. And I do not consider a big role of the ulnocarpal ligaments that could solve the problem with a shortening of the ulna. I would focus more in the dorso-intercarpal ligament, and eventually if I find this laxity or these signs of injury over there, synovitis and friable tissue, a kind of plication. We can do a kind of plication, arthroscopic plication in this area. And again, I would like to comment that I consider the ganglion a clinical sign of some pathology. So that not just excise the ganglion. I would not consider this as a solution, but to look below the ganglion or around the ganglion for a ligament problem.
So who in the audience would shorten the ulna? Okay, Jeff, you have your answer. Please don't shorten the ulna. So, clinical case number 2 from Carla Nunes. So, this is a 50-year-old male, non-manual worker, right-handed, and also playing tennis. He fell from height on the outstretched edge at the age of 2-year-old. At that time, he got early closure of physial plate radius. He got an ulnar overgrowth, and then somebody performed an ulnar shortening osteotomy as he was a child. Again, ulnar shortening and radial realignment osteotomy as a teenager, and then they removed the plate or whatever. And today, he got an ulnar pain, a pain of the ulnar side of the wrist 2 years ago. He already had an arthroscopic wafer procedure. So we've got more clinical information here. The complaints of the patient is a constant low-grade wrist pain and the paroxystic high-intensity wrist pain. He can't specify which kind of movement. He stopped playing tennis and other hobbies. And on the physical examination, there is a little bit shorter right forearm, multiple scar, of course, because he has been operated many times. The skin condition is okay. There is no inflammatory reaction. The range of motion is normal. There is some tenderness and defense. The patient is fearing pain when you touch him. And the most painful spot is the drudge and the LT joint. So there is no ballotment test painful. And there is a slight pain in the radiolunate compartment. So this is the complete X-ray of the forearm. And this is the X-ray that we have today. So, Bo, what do you think about this? What would you do? Again, we don't have the solution. No, you, Bo.
Okay. So, in my impression, according to the history and the physics examination, the pain is mainly focused on the ulnar side of the wrist, and there's mainly at the DRUG area. You have increased pain as you stress or compress the DRUG on a couple.
But no pain at the ballotment test.
Yeah, no pain at the ballotment test. That means there's not much thing about instability, but there's pain if you the patient will compress on the deviation. There's a pain there. So, according to the history and also the X-ray, is a picture of the patient has a ulnar impaction symptom. So for this kind of patient, in my practice, I will order a MRI for this patient to see if any increased signal over the of the neonate and the tracheal as well as the distal ulnar. And okay, this is a CT scan. You can see there's an ulnar plus, and also there is a lesion over the opposite side of the kissing needle of the neonate. So it's this can have more evidence of ulnar impaction syndrome. And if I'm looking at the DRUG, there's also decreased space, decreased joint space. That means there's already some early arthrosis, signs of early arthrosis. And so for if I have a chance, I'll still ordering MRI for this patient to see.
I think I don't have.
Okay, to see the status of a TFCC and also any increased signal.
But there is no TFCC because he has already a wafer procedure.
Yes, we know. So we can see the perforation. We can see the increased signal of the neonate. But for this patient, I believe this is a problem on impaction. I will playing if the patient has failed of a conservative, I will provide some ulnar shortening or the solving carpentry procedure after I lower the ulnar head a little bit. But it's all depends on the status of DRUG. I need more information of the DRUG to decide either ulnar shortening or a solving carpentry.
Thank you, Bo. So Jan, you can see on this X-ray, especially on the anterior posterior view, that you can see a kind of stigmat of wafer, which is probably not completed. But we also have some distal radioulnar joint arthrosis and even a problem of the radiolunate joint on the CT scan. So what is your advice in this?
From what you tell me, it has been shortened a couple of times already.
Yes.
Still, he has a long ulna, so there's probably longitudinal instability as well, which you could consider. He has arthrosis over the radiocarpal joint. He has arthrosis probably over the distal radioulnar joint, which is too long. He's a tennis player.
Used to be, but not professional.
But I don't think he should continue playing tennis. What I could offer him is...
He can start golf?
Exactly, he could. if I would have to talk to him, examine him, of course. And we had lots of discussion, but to solve this problem, I think the mid-carpal joint is good. So I could probably propose a radioscaphoid fusion, and on the ulnar side, I would probably do a prosthesis. If there is any kind of longitudinal instability, I would combine the radioscaphoid fusion with an Aptus prosthesis.
That's very wise. Okay, we have to go on. Clinical case number 3, same from Dr. Nunes. So, yes, it's a male, 53-year-old, a manual worker, right-handed. He falls from 3 meters 1.5 years ago. He got a dislocation of the wrist in both wrists, and he has been operated on with by reduction and ligament repair. I don't know which one. He got a good evolution on the right side, but the problem is on the other side, on the left side. And I will show you the X-ray. And so the patient now is painful and he asks for doing something. And this is what we have today. So I know the X-ray are not so good, but okay. So Marion, what do you recommend here?
So thank you. We just discovered the case. So,
that's me.
Yes, and but we will play the game. So maybe first
there is no solution. So
yes, but we have to find a solution for this guy
to help.
Yeah. So we will ask for a CT scan first. Thank you. Yes.
So
he's 53, manual worker.
Yep. Non-manual worker.
Non-manual worker.
Yeah. Oh, sorry, manual worker. Manual worker. Sorry.
So he needs strength. I think the proximal pole of the capitate is not good enough, and the distal radius is not good too. Yeah. Unfortunately for this guy, I think we will go to a total wrist fusion, because if he's a manual worker, of course we cannot perform any arthroplasty, and it looks like there is neither the radiocarpal or the midcarpal joint that we can save. So I think, yes, I will go to a total wrist fusion, and I didn't see very well the distal radioulnar joint, but it looks to be fine. Yes.
Yes, that's
so
very wise, because yes, there is no other available available joint. So yes, I think you're right. Okay. Clinical case number 4 by Dr. Manjon. So, Eva, prepare yourself. So, this is an 18-year-old male, soccer player, and he got this waist scaphoid fracture a couple of years ago. He has been operated 3 months ago, and open airbag screw somewhere else. Okay, and this is the MRI. We don't have a CT scan. I think I have. Yes, this is what we have here. Even worse. 2 years, 3 years. This is the CT scan here, I guess. And this is the range of motion. Okay? So I'm going back. Oh, sorry. So, what do you recommend now? The advice to Dr. Manjon.
Yes. I think radioscaphoid joint is is gone. The mid-carpal joint between the scaphoid and the capitate is also gone. And maybe or probably the radiolunoid joint is good enough. And unfortunately for this young guy, I think it's only possible to remove the scaphoid, including the screw, and to do a mid-carpal fusion.
Arthroscopically?
Sure. Sure.
Yes, that's not so difficult decision here. And we have now clinical case number 5. This is a 69-year-old patient, left-handed, female. She's not a surgeon because she is retired at that age. She fell from her height and she got right wrist pain. So this is the day 0 of the injury. So anybody from the second row has an idea of what we should do? René? What do you see here? She is 69.
I see disaster.
You see what?
Disaster.
Yeah.
Multifragmentary distal radius fracture and displacing and volar displaced principally, and subluxation volar in the carpal with the fragment. The probably is the quality of the bone is bad. I think that in the first moment is the fixation, external fixation used in the tractional ligamento-taxis for the distal radius fracture, and decision of the final treatment is post fixation or external fixation.
Gustavo?
Just to make clear the story, it was a real trauma, or was
yes,
a burnout?
She fall down like a 69-year-old woman.
Because I just had an X-ray just like this in a rheumatoid patient with volar lip fracture and with no big trauma involved, but she just appeared with this big deformity and this situation. So and you see the bones has all these changes, the cystic changes, the calcifications around. So I'll be concerned about some systemic problem.
Yes, you're right. She got a rheumatoid arthritis and, of course, this volar fracture. But at that time, the surgeon who took care of the patient didn't know that he had a rheumatoid arthritis. He didn't mention it to the surgeon. So the surgeons did almost nothing. And now I see that patient in my office 4 months after the injury. And I know that he has a rheumatoid arthritis. And now that he has this malunion, volar malunion. Guillaume.
Yes, I think it's an indication for a total wrist arthroplasty combined with a Dirac.
That would be exactly what I wanted to do. Exactly this. But the patient has strictly no pain, a range of motion about the same from the other side. The only problem is a lack of extension, a very good quick dash compared to her condition, and very good motion. I agree with you, Guillaume.
No, this is one more reason to begin with clinical examination.
Absolutely. Absolutely. So when I saw the X-rays, before I saw the patient, usually I like to see the file of the patient before. I was like, I will make a total wrist. And when I saw that patient with this condition, I say, oh, that's a good result. You know, the surgeon who took care of you was a very good surgeon. Please come back to me in any case you have any problem.
We have to mention that she may have in the future a severe carpal tunnel syndrome, which could be a good reason to operate on her.
Yes, you're right. So, Christophe, would you like to conclude?
Yes. So, dear friends, thank you very much. It was really funny because during the presentation we received WhatsApp from China, from South Africa. So, hello friends, we are with you. It's very, very nice, and we'll continue. And the next seasonal forum will be in February, 29 February, because next year we'll have 29 days in February. Thank you very much. Goodbye, and see you later.